So let's talk about some of these strategies. So we have approval of several of these strategies in the neoadjuvant and the perioperative strategy. Many are FDA approved, including CheckMate 816 with Nivo plus chemo in the neoadjuvant strategy. And then we have the perioperative approaches with Keynote 671 with perioperative pembrolizumab plus chemo, the Aegean with perioperative durvalumab plus chemo, and then the CheckMate 77T with the perioperative Nivo plus chemo strategy. And we saw some interesting updates at ASCO 2025 about results from CheckMate 77T. And just to kind of go back and give a short, brief update on the CheckMate 77T, this is a strategy that used perioperative chemotherapy plus nivolumab, preoperative for stage 2A, 3B non-small cell lung cancer, and then patients received surgery and then went on to receive an adjuvant component of nivolumab every 4 weeks for a year. And we saw that study met the primary endpoint of event-free survival. In the update at ASCO 2025, we saw some interesting data with additional follow-up of 41 months, that the combination of Nivo plus chemo in this perioperative strategy continued to show improvement in the long-term event-free survival, as well as a favorable overall survival trend. And there were no new safety signals that were observed at this extended follow-up. In addition, we also saw an exploratory analysis that showed that pre-surgery circulating tumor DNA was associated with this EFS or event-free survival benefit. So comments on this updated follow-up for CheckMate 77T, how does that influence your decision-making on how to integrate perioperative chemoimmunotherapy? And does that impact your surgical planning and timing?
I think one of the things that I was excited to see that, because we all know, right, that for patients that have complete pathological response, then they tend to have like an improvement EFS. But in this study, they showed that for patients that have clearance of the ctDNA, they actually had an EFS benefit regardless of whether they had a complete pathological response or not. I think, at least in our institution, it's something that we really incorporate for patients that are, again, resectable, good performance status. If they have tumors greater than 4 centimeters, it's always something that we discuss. I think the point for us medical oncologists is like, we never thought that having too many options was going to be a problem, but like now, how do you choose, right? Like some people are just like super comfortable with pembrolizumab and that's just their go-to, their CheckMate 671. Some people prefer Nivo. I think Nivo was the first trial to become approved, the CheckMate 816. At that point, it was only 3 cycles of neoadjuvant chemo rather than 4. So I think when they designed the CheckMate, they added that 4th cycle in the neoadjuvant setting and also added the adjuvant immunotherapy. But definitely, this is something that is very impressive to see, that it's something that we really want to have options to present to our patients, and it's something that I incorporate in the practice. I would say that I use more this CheckMate 77T and the Keynote 671 rather than the 816, just because that adjuvant component. But I think in the future, the ctDNA will really be able to hopefully guide us as to who really needs that extra year of immunotherapy, and are we overtreating, right? Because in the end, we want to make sure that we're not only treating ourselves, but that there's really like a necessity and a benefit that is provided to our patients.
And Coral, are you incorporating the ctDNA, and are you following patients for ctDNA clearance to kind of correlate with EFS as we saw in CheckMate 77T?
We just opened our own IIT, and I will start enrolling patients. I hadn't done that yet because I feel like sometimes patients fixate on the ctDNA and it becomes confusing, and because there's really a lack of FDA recommendations and really like grasp for data, I was holding off. But now that my colleague I think just this week, the trial was approved and open for accrual at the university, I think it'll be nice to kind of like see it in that proper setting. How about you? Do you do it?
Not yet. I'm with you. I think we need more data.
Yeah.
But I do think it is kind of where we're going to see future directions going. But let's go back to the preparing patients to undergo surgery. So now the patients have undergone preoperative chemoimmunotherapy with your choice of the perioperative regimen. As surgeons, Mara, tell me, like, how do you prepare your patients? How do you communicate with MedOnc in terms of making sure that everybody stays on track to manage side effects so patients don't get off track for surgery, but importantly, that the timing like works as best as possible for surgical planning?
Yeah, when we determine upfront that a patient is intended for perioperative therapy, we typically, for us, it's often emails or text messages, or people send messages through EMR. There's a variety of different ways to have communication, but whatever the method of communication is, we try very hard to have communication that involves the surgeon and the medical oncologist, as well as the teams that support us, that nothing is relying on one person, recognizing that there are a lot of elements to the complex puzzle. But we try to talk about when the patient is supposed to start their therapy and when they're intended to finish. We recognize as surgeons that it's not as scheduled as we always want it to be. We always think, well, they're going to start it on this day. Obviously, they're going to be done on this day, and that's the day that we're going to operate. And it doesn't always work out that well. Our medical oncology colleagues often will get imaging after 2 cycles to ensure that things are going the way that we want. We don't always see them after those 2 cycles. But we have an understanding and expectation that we as the surgeon may hear if there's been an issue, if there's been a change in schedule, or if things aren't going the way that we want, so we can reassess, review the imaging together. But as long as things are on track, it's often expected that after they have kind of the 2nd cycle, we may have an additional communication that says, okay, this is when we expect the last cycle to be, and let's schedule like a planned in repeat imaging with visits with both parts of the team to work on surgical planning. And I think every surgeon has different timelines for how far they book out. Some of us further than others. But when you have just continued communication, I think that's a key part of it. And like I said, the communication is going to be different in every healthcare system and how you do so. But I think it's just important to have a plan of care at the outset. If there's going to be repeat imaging during the initial couple cycles of treatment, that there's some communication with a planned end date. And I think we as surgeons need to be flexible, not only in understanding that sometimes there may be a decision not to do the 4th cycle, or these things may get actually pushed back due to toxicities. I think we need to be more flexible as surgeons. We need to listen when our medical oncologists say, hey, this person's experiencing some pneumonitis or some, thyroiditis or, delayed return of marrow function. We just have to be willing to kind of be adaptable. And we have these ideas in our head that surgery has to happen on a certain timeline based on the studies that we've seen. But ultimately, the patient safety is the most important thing. And so something gets delayed because you have to work out, management of their pneumonitis or management of adrenal insufficiency or whatever it may be. I think we just need to be patient. We need to learn to be more flexible and have wide open communication to keep the patient's safety as the foremost goal.
And I do think it's like really critical to have that point of communication following cycle 2, because if you have a borderline resectable patient, or there are things as a surgeon that you're worried about, that following cycle 2, you're just like, this is not going the way that I think we need to go in order to get to that point of the best or optimal surgical resection, then I think you need to know like right then and there, right? Because if that's the case and you're like, yeah, this is kind of not what I had hoped to see in order to take this patient safely to surgery to have the optimal outcome, that may be a critical point where we need to pivot to chemorads. And then I want to make sure radiation oncology weighs in as well. So I do think that even if the med-onc thinks it's like going really well for cycle 2 post imaging, I think we need to have a really critical review of that imaging as a team.
Yeah. And I think we've also had the situations where after 2 cycles, things aren't responding at all. And you might say, and you might not pivot to radiation. You might actually say, this was resectable before. We were hoping to get the benefit of neoadjuvant therapy, but we're not getting a benefit of neoadjuvant therapy. So let's not lose our window of resectability, because sometimes things start out as resectable, but we just hope to have an oncologic benefit of the perioperative therapy. And if the systemic therapy is not helping for whatever reason in that individual's case, it might be time to operate now and then get those great pathologic endpoints that will guide us. Why wasn't it working? Is there a role to adjuvant therapy? Are we totally wrong about about the biology of this patient's disease. And so, yeah, all of that communication, I think, is incredibly important. And it's difficult for us in our respective situations to prescribe what every communication strategy should be in different hospitals, but whether it's every patient gets brought to tumor board, or if that's not feasible, do they have group text? Do they have, my chart inboxes, or how do they do it? Everyone's going to find the way that works for them. But I do think we have to drive home to all of our colleagues, regardless of the healthcare setting in which they practice, that this continued communication is incredibly important. And we are long past an era where it's like early stage goes to the surgeon, metastatic goes just to the medical oncologist. Everyone needs to see everybody at this point. I mean, it's good for patients. It's good for all of us. I think we just all need to be involved in every patient, regardless of the stage of disease.
And I think also bringing up that point is because obviously, we have community oncologists that see everything. I don't even know, like, hats off to them. But like at any point, you need to ask a colleague, or like someone, like you said, like us have the privilege of only seeing lung cancer, or like just 2 tumor types, to really like make sure that we make ourselves available for them, to guide them in any case, or to just listen, like, this is what I would do. Happy to run by the case, like, after you do two of the cycles of neoadjuvant, or even with dosing, or even what regimens to use. I really try to as much as I can, for the patients that I see as a second opinion, if they go back, whether that's because it's closer to home and I don't want them to travel 3 hours, I'm happy, and try to really kind of like keep that line of conversation going. So I think as a responsibility that some of us in academia have, is to really kind of like be allies to our community doctors, and help guide them, because this is really what we do day in and day out. We have the luxury of not having to see 30 tumor types in one given day.